Thank you for the kind introduction. I also thank the organizers for inviting me, and I thank Professor Czlonkowska for a very nice collaboration with her and her team. So my task is to tell you some remarks on the neurological manifestations of Wilson disease. And I start straight away with the patient. Hopefully. Okay, so this is a patient who appeared at our movement disorders office, and you see some dystonic posturing in the upper extremities. You see some mild cervical dystonia with the dystonic tremor. You could hear also some dysarthria if there was a sound. There was also a slowing of repetitive movements without clear decrement. And upon gait, you can see a mild resting tremor appearing on her right upper extremity. And when you see her history, she was born more than 50 years ago, and her family history is negative. And her personal history started when she was 49, and in her was discovered incidental hepatopathy on abdominal ultrasound, which was performed due to hematuria, I believe. And she was sent to hepatology, and they performed liver biopsy, which showed steatosis. No other examinations were done, and she was dismissed. And 2 years later, when she was 51, she developed tremor in head and in both arms. 1 year later, she developed impaired speech, and another year later, she developed fatigue and gait instability. And this is the video you have just seen. Of course, neurologists, when see patients like this, they usually perform brain MRI. And in these patients, you can see some T2 weighted signal drop in the basal ganglia and thalami, some very mild T2 hyperintensities in the putaminal rim. You see very prominent hyperintensities in the dorsal mesencephalon and in the pons. On the sagittal T1 weighted image, you could see that these hyperintensities have reflection in the T1 hypointensity, which is always a bad sign because it means that there is more severe tissue damage. Just by knowing this, experienced neurologists can hardly think about any other diagnosis than Wilson disease. And because this MRI is fairly specific. This could be like osmotic myelinolysis, but it does not really affect the dorsal mesencephalon. And in osmotic myelinolysis, you don't see these profound T2 hypointensities in basal ganglia. And in fact, the urinary copper expression was increased, the ceruloplasmin was decreased, the slit lamp examination revealed no Kaiser-Fleischerring, and at the next stage, the liver copper was increased, and the genetic exam confirmed the most prevalent mutation in the Central Europe. There are 3 learning points in this case study. First of all, the Wilson disease may appear after the age of 50. This is well known, but it still needs to be reminded. The second point is that the neurologic Wilson disease patients may be negative for Kaiser-Fleischerring. There were some reports showing that this is 100% sensitivity, but there is no 100% in medicine, and in Wilson disease, not at all. You may always argue that the ophthalmologist was not experienced, but this was done in a tertiary center, and these neuro-ophthalmologists have seen more than 100 of Wilson disease patients. Still, they may do mistake, but that's what you get, and you have to believe your ophthalmologist. And the third learning point is that these patients should have been diagnosed by the hepatologist 3 years before the neurologic symptoms appear, and the hepatologist always needs to think about Wilson disease, even in elderly patients. Okay, let me show you another presentations. Okay, this is one of the most specific sign in Wilson disease, and it's a very typical tremor, which is asymmetric, it's proximal, and it appears in the wing beating position, and it appears with some latency. Whenever you see tremor like this, your suspicion for Wilson disease needs to be really high. It's not 100% specific though. I have seen tremors like this in FXTAS, for example, but it's very suggestive. There are mentions about neurophenotypes of Wilson disease in the literature with various modification. This is from the latest edition of Up to Date, and they say that the patients may be tremulous, dysarthric, pseudosclerotic, dystonic, Parkinsonian. Might be helpful, but not always. Let me show you another patient. So from the beginning, you can see some cervical dystonia. You can see dystonic tremor. You see probably some ataxia or intention tremor. And again, some dystonic posturing. So you don't know whether this patient would fit into the tremors or dystonic phenotype. This is yet another patient. May I have a sound here? No. Okay, this was a patient who presented when he was 55 years old with severe dysarthria, which you cannot hear, and general slowness, and there was symmetric Parkinsonian syndrome with hypokinesia and rigidity. So this patient may fit into the Parkinsonian and dysarthric phenotype. And when you look into his brain MRI, you see again some T2 hypointensities in globus pallidus, some mild T2 hyperintensities in putamen, and very fake hyperintensity in the brainstem. So this MRI is not very conclusive, but still he was confirmed by genetics. This is yet another patient. This is not tremor, but you see it's looks like myoclonic jerks. This is again not tremor. This is a negative myoclonus, which we call asterix, and this is marker of hepatic encephalopathy. It's a very important sign to look for in Wilson disease patients. Okay, so the finger to nose test is rather normal. There is no marked tremor here, but as you will see later, very violent tremor will appear in the posture holding position. Yeah, so this is again this very specific type of tremor. Okay, this is another patient with a prominent resting and action tremor, and his basal ganglia were pretty normal, but you could see this very specific T2 hyperintensities in the dorsal mesencephalon in pons, and you see that these hyperintensity spreads along the dorsal rim of a brainstem. So these patients would pretty much fit into the pseudosclerotic type. And this is another patient on a long-term treatment, which was not very successful, as you can see from his brain MRI, and you see very severe necrosis of his both putamina. He was severely dysarthric and unstable. And what you can see on neurological examination, he has severe freezing, severe hypomimia. and no response to levodopa. No wonder when you see his putaminia. Okay, so the phenotypes may be helpful in part of the patient, but in general, most of the patient present with combined phenotype, and there are common and less common signs. The most common is dysarthria, tremor, Parkinsonism, dystonia, and ataxia. I've taken these numbers from these studies. Much rarer are positive pyramidal signs, chorea, myoclonus, epileptic seizure, eye movement abnormalities, and sleep disorders, including REM behavioral disorder. And on MRI, you can see basically 3 types of abnormalities. The first and the most typical is T2 hypersignal, which may mean demyelination, gliosis, and tissue rarefaction. When the rarefaction gets severe, you can see it as T1 hyposignal, which may indicate necrosis. Then you see T2 or T2 star or SWI hyposignal, which, as I will show you later, means iron deposits. And the third is atrophy, which is basically a tissue loss, and it's similar to this rarefaction. And there is specific pattern of abnormalities. The mostly affected regions are basal ganglia, brainstem, little bit less thalamus, and much more rare affected regions are cortex and white matter. As a neurologist, you always think about topic diagnosis, and you try to connect these lesions of these structures to these phenotypes. It works in part. There were some studies showing that the dystonia and Parkinsonism are related to putamen lesions. There were studies showing that the white matter and cortical lesions are related to epileptic seizures. But we don't know for sure how tremor is generated, for example. This is a very typical sign. As I already told, the posterior mesencephalon is fairly commonly affected, and then the basal ganglia. But these are not 2 separate lesions. But when you look at the coronal slice, you see that it's the whole pathway that is affected. That this pathway is going from the superior cerebral peduncle. It goes in the posterior parts of mesencephalon, that it crosses along the nuclear rubber and goes to thalamus, and this is dentatorubro-thalamic tract. And I believe this is related to the tremor, but there are no hard data on that. What is very typical is the bright claustrum sign, these very bright regions on the rim of a putamen. And then also these T2 hypointensities. The pattern of atrophy is also quite specific. This is a healthy control on the left, and this is patients on a long-term treatment with Wilson disease. And what you see is a profound atrophy of a mesencephalon. This is a normal size mesencephalon. It's very convex shape. And in a Wilson disease patients, it's profoundly atrophic. And here on the sagittal slice, you see that the mesencephalon is almost gone. And I know only one another diagnosis that could make such a severe mesencephalic atrophy, and this is PSP, progressive supranuclear palsy. So whenever you see this pattern in a younger patients, you must suspect Wilson disease. Okay, so back to the T2 hypointensities. There were long-term ongoing discussions whether this might be effect of iron accumulation or paramagnetic effect of copper. That's why we did this ex vivo study, and I'm showing you an post-mortem MRI of a healthy control and of a Wilson disease patients, and at the first look, you can see that there is profound hypointensity in the putamen and globus pallidus in the Wilson disease case. When you do an DAB enhanced thermal iron staining, you see that not only there is more iron staining, but the structure is disrupted. You see these nice bundles passing through the putamen and to the globus pallidus, and the structure is damaged here. On high power images, you see that the Wilson putamen is completely mass, and there are huge spots with iron staining. And when we did the double staining, we have found that the iron is contained in astrocytes, so double staining GFAP and iron, but mostly in macrophages, so KM1P and iron predominantly present around vessels. And the quantitative measurements using ICP-MS showed that the iron was significantly increased in a group of VD brains compared to controls. And when we did correlation of the iron concentration with R2 star, which is a quantitative MRI parameter reflecting iron concentration, there was very tight correlation with iron concentration, but no correlation with copper. So that is a proof that these T2 hypointensities reflect iron accumulation and are not related to copper. Copper is invisible for MRI. Another histology to imaging correlation study shows another postmortem slice with a profound hypointensity and iron staining, showing that the putamen is very damaged. And in those lateral parts where you see a T2 hyperintensity, you see that there is profound gliosis with this typical astrocyte. But in this central part, which is more damaged, you see very profound tissue loss and lots of macrophages. And when we performed ferritin staining, you see that these macrophages are very positive for ferritin, which is paramagnetic and causes this T2 MRI signal drop. This is one of our longitudinally followed Wilson disease patients, and this is R2 star, which I've shown you that correlates with iron. And you see that when the treatment began, this patient continued to accumulate iron in his basal ganglia. And at the same time, there was increasing atrophy, that the third ventricle increased, the thalami shrink, and the putamen also shrank. And this region in the thalami developed ultimately cavitation with a huge positivity with R2 star, so it means that there is lots of iron accumulation. So and this was a rather unsuccessfully treated patient. And of course, there needs to be lots of group studies that to be done, but it seems that the iron accumulates during the treatment, particularly when the treatment is not very successful. We also did a
2 minutes.
We also did a group study in vivo, and this is another quantitative MRI parameter that is relevant to iron susceptibility. And you see that these neuro-VD patients, which are in red, have much higher values compared to controls in all the regions that were examined. And you could see that in an e-poster that was presented this morning by my colleague, Monika Dezortová. What is very interesting that in this group cross-sectional study, there was different pattern of age-related iron evolution in neurologic VD patients compared to controls. It's been known since the beginning of 20th century that during aging, iron accumulates in brain. And this is particularly true for putamen. This is what we have observed in our controls. But in the neurologic VD patients, the older patients, they decreased the levels of iron, particularly in globus pallidus, in substantia nigra, and in thalamus. And you couldn't see the physiologic increase in the putamen. And there is a question whether there is an early rise in iron in the brains of VD patients and later decline. And something similar was described in multiple sclerosis recently. And there are more studies needed to be done on this topic. I think I need to skip a few slides, just a quick note. This Leipzig diagnostic score was developed for hepatologists and is less useful for neurologists, particularly for this reason. Neurologic symptoms or typical brain MRI gets 2 points. When you are sitting in a neurologic office, every patient who enters have 2 points already. And second, the typical MRI is not the same information, it's complementary. So I suggest the neurologists, when they ask me how should I screen the patients, I advise them to use this three-stage screening procedure. First, estimate probability, second, perform screening, and third, confirm diagnosis. And you can stop at any of these levels. First of all, ask about hepatopathy. Family history, is there progressive disease? Is it polysymptomatic? Is there a typical MRI? The more yes you answer, the more likely the Wilson disease is. And the most important is the first one, is the hepatopathy. Whenever you have unexplained hepatopathy, you must go to step 2. When you answer no to all these questions, Wilson disease is less likely. It's not validated, but it proved to be helpful. When you decide to perform screening, you have to do it properly, do ophthalmology, serum ceruloplasmin, and urine copper excretion. And then when the diagnosis is not clear, you should go to the next step, and it's ATP7 mutation analysis or liver biopsy. And I think I just need to quit here. And I thank you for your attention.